Now, after palpation, what you have to do is the percussion. Now, I always say that percussion is an art. And what is art? It requires practice, without saying. So, not that you will learn percussion very quickly. So, I always say whenever you get an opportunity to examine a patient, you must percuss. This is for one reason. And the second reason why you percuss, because in percussion, there are many rules of percussion. You can read in any books that you use 2 fingers, pleximeter and plexor. And there are many rules have been written, and those rules has to be followed. I will not go into details. But while doing a percussion, what is the first thing what you have to decide is first you have to percuss all over the chest, and the first thing you percuss is over the clavicle. And over the clavicle, the percussion is without pleximeter. It is the direct percussion. You stretch the skin over the clavicle and you percuss and compare with the opposite side. Then you percuss front of the chest, compare it from the other side, back of the chest, compare it from the other side, then axilla and compare it from the other side. That is how percussion goes. And why I was telling that it is an art, because while you percuss, the normal percussion note may differ from individual to individual. That is one. Not that every patient you are percussing you find the same, although there will be normal resonance, but it may differ depending upon whether it is thin chest, more muscles, less muscles. It will be resonant, but the note may differ. And even in the same patient, from area to area, the normal resonant note may differ. Means in the area where there is a less muscle, say infraclavicular area, there is less muscle. There the normal resonant note may be little different as compared to a suprascapular area where a lot of muscles. Less muscle in infrascapular area, less muscle in infraclavicular area, more muscles on supra. So, that is why it requires a practice. That normal percussion note, what you have to identify, what you have to keep in your mind, that it may differ from individual to individual. A person who is 30 kg and a person who is 90 kg, there the muscle and everything would be different. So, their note also will be different, but believe me, they are all normal percussion notes. So, while you have percussed, and the another thing in percussion is that while you percussion on the right side, you find front of the chest, you find there is a liver dullness, and liver dullness is usually from the resonant note you find a dull note, and that is called as liver dullness. It is percussed in the mid-clavicular line, and usually liver dullness is present in 6 intercostal space. Since it is a comparative finding, so what happens when you percuss on the right side and compare it from the left side, so wherever there is a liver dullness, on the left side it will be a tympanic or hyperresonant note because of the TROPS space. That is the normal finding. So, those normal things you have to always remember. And TROPS, what is the TROPS space? TROPS space is a just like you percuss on the left side, it starts from above and come to the down, then from resonant node will be followed by hyperresonant node or tympanic node, and that is the area of a TROPS space. TROPS space, believe it, many of the students don't understand, this is not the area of abdomen, this is the area of chest. That is why it is to our interest. And so, TROPS space boundaries could be, the upper boundary is the lower border of the lung resonance, and lower boundary is by subcostal margin. That is why I said the trough space is the finding of the chest, not the finding of the abdomen. If you go below the subcostal margin, it will be a hyperresonant node because of the fundal gas shadow. And this trough space, the medial boundary is by left lobe of liver and lateral boundary is by the spleen. So that is how it is a semilunar area, hardly 1 or 2 finger wide, just above the subcostal margin. You find a hyperresonant or tympanitic node that you call as a trough space. Now trough space, so while comparing right and left, you will find in contrast, here you find a dull node because of the liver dullness, here you find a hyperresonant or tympanitic node because of the trough space. That you have to remember, always remember, keep in mind. Many times we ask that in pleural effusion trough space is obliterated. This is wrong. In a massive pleural effusion, it may be obliterated, not necessarily. But trough space is usually maintained. But trough space will be very wide in cases of eventration of diaphragm, in cases of herniation of lung. So that in that way, sometimes there is a paralysis of the diaphragm by phrenic nerve paralysis. The trough space may go up. But trough space is more important because it is a comparative finding. You must know that it will be different from right as compared to left side. So while you, as a clinician, I always say that when you percuss, when you have percussed all over the chest, what you have to first define is the what is normal resonance. And I have already talked to you, normal resonance, it varies, there is inter and intra-individual variation. It varies from person to person. It may vary from area to area in the same person. That is why you have to learn while you percuss many times you can learn this, that this is a normal note. Now, what are the notes which you encounter in your day-to-day clinical practice? That probably I am going to show you with this diagram, that more than normal is what you call it as hyper resonant. Even more than hyperresonant, what you call it as tympanitic. So, above the normal resonance, there are hyper or tympanitic. And hyper or tympanic suggests you that there is a more air either in the alveoli or in the pleura. There are two structures, and in disease wise you may convert it into either it is a COPD or emphysema, or else it is a pneumothorax. That is how you find what are the causes of a more than normal resonance. Now, less than normal resonance, the first note what you encounter in day-to-day clinical practice is known as impaired note. Or you can also call it impaired resonance, but you cannot call it impaired dull. Dull is dull. So, what do you mean by this? There would be resonant node, but it will be less resonant. That means it is impaired resonance. And what it suggests to a clinician? Suppose I percuss and I found in one of the apex there is an impaired note. It means some disease is there at the apex of the chest. Just started. Like say some tuberculous infiltration. Say suppose you find impaired note at one of the bases. It may be a early consolidation, just beginning of pneumonia. It may be just beginning of the pulmonary edema, congestive heart failure. So, those things where there is it may be impaired note. anything disease which is beginning. So impaired note. After impaired note, what note you encounter is the dull note. And dull note implies to a clinician either there is a consolidation, complete consolidation, or there is a collapse. These are the two situations where you can find a dull note. And further, there is another note which is described, which is very common, is the stony dull note. When I say stony dull note, and you know, while seeing all these sets of resonance, from this to dull note, it is the sound which matters. Means if you are percussing, I am listening, I can also listen these things. But dull note, as I said, dull cannot be further impaired. Dull is dull. There is no further impairment. So in stony dull note is the dull note. Note is same. Plus it is the abnormal feeling of resistance to your percussion finger. So in stony dull note, there are two components. Resistance. What are those two components? Is that note would be dull, and while your finger pleximeter will feel some resistance. And as dull note suggests consolidation, collapse means complete airlessness. The stony dull note suggests pleural effusion. So that is how you react with the various type of notes in the percussion. Now there are one or two more points which you have to remember while doing a physical examination, especially percussion. That you know that if you talk about the pleural effusion, I talked that the fluid is the main cause for the stony dull note. So always remember a dictum. When there is a fluid, search for air. And when there is air, evidence of air by a hyperresonant note, you must search for fluid. Because many times what we have seen, they are associated together. So when we are talking of a pleural effusion may be in general pleural space, in a free pleural space, which is very common. Pleural effusion may be encysted, and there are many pockets, many types of encysted effusion. And then the pleural effusion may be also associated with air, what you call it as hydropneumothorax. Now, how to differentiate in percussion these three things? Between a pleural effusion in free pleural space and hydropneumothorax. What you have to do, suppose this is a front line, you have to percuss on the front, and you find suppose area of stony dull note starting here. Then you percuss into the axillary line, suppose area of dullness starting like this, and you percuss over the back, so it will come like. So in a case of free pleural effusion, highest point of dullness goes into the axilla. But suppose there is air and fluid both, means hydropneumothorax, what you will find that here front line, here it is the back line, and here is the axillary line. All the three will have in the same level. What you call it, the upper level of stony dullness is horizontal. Always examiner asks you, have you marked it? and that is the indication that there is air and fluid both. If you find, and in case of insisted pleural effusion, there will be no any normal behavior, it will depend upon where pocket is. If it is in anterior parietes, if it is in posterior parietes, if it is in axillary wall, if it is so, depending upon that the stony dull note, it will not behave in any way, right. So that is how you differentiate between pleural effusion and hydro. And when you find this type of a finding, examiner always asks, have you marked it? Then not that in every case of a pleural effusion you may go for the shifting dullness, but I will talk about shifting dullness, especially you find this scenario. What shifting dullness ideally means is immediate shifting dullness. When I say shifting dullness, everybody means this is immediate shifting dullness, means the time you take to change the posture of the patient. Hardly maybe 30 seconds or 1 minute maximum, 30 seconds. In the same time, this level will change. The area which was dull, it will become a resonant or hyperresonant note. So that is known as a shifting dullness, and shifting dullness is the most pathognomic physical sign for hydropneumothorax. If anybody asks what is the most pathognomic, because there are few more physical signs which I am going to tell you about the hydropneumothorax, but this is the most. So upper border of the dull note is straight, immediately you go for shifting dullness, and there will be positive. Shifting dullness positive means area which was dull, it will become resonant. And then if you find this, then the third physical sign, although this is a sign of auscultation, percussion, palpation, whatever you see, is you demonstrate the succussion splash. Succussion splash, what is done usually in succussion splash, you ask the patient, it is done usually in the sitting posture. Before you do it, you must explain to your patient what you are going to do it, otherwise patient may behave very violently. So you did that, I am going to shake you very vigorously. So you shake the patient very vigorously, and same time you auscultate and you find a splash sound. As you find there is a water into surahi, you must have seen, if you just shake it, if it is half filled, if it is full filled, it will not behave like that. Half filled, you will find a splashing sound. Similar splashing sound is heard. It is not only theory, it is heard. And so whenever you suspect hydropneumothorax, you must look for the straight border, you must look immediately for shifting dullness, and you must go for succussion splash. Another physical sign which is associated with wherever there is a pneumothorax, whether it is plain pneumothorax or hydropneumothorax, is the coin percussion. And in coin percussion, what you do, instead of those two, flexor and fleximeter, you take help of two coins and keep the coin over the chest, percuss with the another coin and listen corresponding over the back. So what you listen in auscultation, the tympanic or some tympanic sound is added to these coin sounds, and then you call it as that coin sound is positive, coin percussion is positive. And this goes with the new diagnosis of pneumothorax either alone or with hydropneumothorax. So these four physical signs, they are associated with each other. So as a clinician, not that every patient who has come with you and you will vigorously shake, patient will slap you. So you first suspect that yes, I am looking, I am seeing that there is evidence of air and fluid, and then these special physical signs are demonstrated. The another point, another question which is asked in PG examination, can you get shifting dullness in pleural effusion? This is a $100 question, and its answer is yes. If there is a fluid in the free pleural space, it will shift. But the shifting dullness of pleural effusion and shifting dullness of hydropneumothorax, there is a difference of 15 minutes, 15 to 20 minutes. So that is why usually what we say that shifting dullness, usually we do not do in pleural effusion, because there are enough signs to diagnose pleural effusion. But if somebody asks you whether you can, somebody asks you to differentiate between pleural thickening or pleural effusion, so probably this is the physical sign where you have to go for the shifting dullness. I must have shown you in X-ray is the infrapulmonary effusion. So what you do is a lateral decubitus views. And if you ask any radiologist or radiographer, they say that they have to wait, not just lying down and they will do the X-ray. They have to wait for 15 to 20 minutes, because here if the fluid is alone, it takes time to shift. But yes, ideally speaking, that also shifting dullness would be positive, and that is what known as delayed shifting dullness. So when we say shifting dullness, it means immediate word is hidden there, it's immediate shifting dullness. So that's about the various type of notes, various special physical sign. And another physical sign which is also demonstrated in percussion is the chronic isthmus. Chronic isthmus. And chronic isthmus is nothing but it is a band of resonance which connect from anterior to posterior chest wall. So what you do, you start percussing from lateral side, from the neck until you get a resonant note, mark that area. Then you start percussing from the medial, from the shoulder till you get a resonant note, and this span between these two resonant points, this span is, so chronic isthmus is always said that normal span of chronic isthmus is again 5 to 6 centimeter. So it can be reduced on one side, it can be absent on one side, and it always speaks about that there is a disease in the extreme apex of the lung, which creates airlessness. So that's about the chronic isthmus. Anything else in percussion we do? Yes, cardiac percussion, you must know that first, to know the cardiac percussion, you should know how the pleura is reflected. Now, if it is clavicle, so pleural reflection starts just above the clavicle on the right side, and it comes into parasternal line, and then at the 6th spate it turns, and 8th, and finally it goes into, so that's how on the right side. How it is reflected on the left side? Left side is different as compared to right. On the left side it starts here, and then at 3rd level it goes like this, and then it comes here at the 6th. So what is superficial and what is deep cardiac dullness? That question many times is asked by examiner which are little older. So if you see this, that's why you see that if you percuss on the right side, immediately you come and find a liver dullness below it. If you percuss, what is deep cardiac dullness? Deep cardiac dullness is very simple. It is a percussion of the heart borders. Means you percuss left heart border and you percuss the right. Right heart border is normally not percussible. Left heart border correspond to the apex beat. Then there is another term which is used is superficial cardiac dullness. What is superficial cardiac dullness? Is the bare area of the heart. Means here you see the reflection, so there is some 2-3 spaces, 3rd, 4th, 5th, 3rd, 4th, different books, different. You find that pleural reflection goes away. So this becomes the bare area of the heart. It means lung is not here, but lung is behind the heart. Lung is behind the heart. So if you percuss, for superficial cardiac dullness, it must be a very light percussion. Because as I said that lung is behind the heart is there, if you percuss it very deeply, you can pick up the lung resonance from behind. So it should be very light percussion, and in the parasternal line, in 3rd and 4th space, what normally you can find the dullness of the heart, because front of the heart there is no lung because of the pleural reflection. So that space is known as superficial cardiac dullness. And superficial cardiac dullness and deep cardiac dullness, they are masked when lungs are overinflated, means COPD and emphysema. When lung volume will increase, they will cover, lung will come over here, so these dullnesses will be masked. That is why we say superficial and deep cardiac dullness are masked in case of COPD. But appreciation is very difficult. That is why if you just do a very light percussion, then you can pick up the normally superficial. It is normally